So, good morning, everyone, or afternoon, as I mentioned, depending on where you are. So, thank you so much for joining us. We're going to go ahead and get started. For those of you that may be joining us for the first time, my name is Dr. Hewlett Lyons. I'm the current chair of the SIG, and we are really excited today to have with us Dr. Nicole Pylan, who is the Family Therapy Clinic Director and Associate Professor of Practice at Texas Tech University, and Monica Osterbeyer. She is a PhD student at Texas Tech University, and they're going to be speaking to us today about the development of the integrated behavioral health startup program there at Texas Tech. So they will be answering questions towards the end. They've asked if you put your questions in the chat, if there's opportunities to answer those questions as they're going along, they will do so, but they most certainly have designated some time at the end of our webinar today to answer your questions. And then they've also moved forward with putting their information in the chat. So if you have questions that extend outside of the time that we have today, feel free to reach out to them via email. So thank you so much for joining us, and I will pass the floor on to you all to get started.
Perfect. Thank you guys for inviting us. It feels like such a privilege to talk a little bit about the work that we've been doing over the past several years. And so we are providing services in our University Medical Center Children's Hospital. And so we want to share our narrative, and we hope that everyone will have a little bit of something that they might take away from the things that we've been doing and what we've been learning and will continue to learn in our integrative care journey. So like she said, I'm Dr. Nicole Pylan. We're with Texas Tech University, the College of Health and Human Sciences, and I have a position across both the TTU main campus, the Health Sciences Center, and within the University Medical Center Children's Hospital. My
And my
co-presenter.
name is
Yes.
Hi, everybody. My name is Monica. Good to be here with all of you. I am a PhD student and research assistant in the couple marriage and family therapy program here at Texas Tech.
All right, just to cover a little bit of housekeeping, we're not selling anything, we're not compensated for our presentation, and we have no conflicts of interest. We want to be able to share a little bit about what we've done over the past several years, and includes some of the expansion of our role at the hospital within the Pediatric Oncology unit. We hope to offer you some practical steps and insights from both our clinical team as well as a patient family provider system. And then close it out with some lessons learned and hopefully some useful tips if you guys are in a situation where you might be expanding services or really developing something from the ground up. These are our objectives, which are very similar to what I just highlighted, so I won't spend a lot of time there. But I think that this slide here really kind of captures the journey that we've been on. A colleague of mine said this early on in the process as we were trying to function with, a limited budget, new space, opening a second clinic, that we're riding a bike while we are building it. And it doesn't feel so much like that anymore, but that is definitely kind of how it felt in the beginning of the journey. So to offer you a little bit of history and background, we had the very first conversations with some of the stakeholders at the hospital in January of 2018. And I created this timeline. It's kind of busy, but really the color coding is to highlight that there are a variety of activities that we have put our energy into over the course of the last several years. And the initial startup, we had to get it credentialed through the Health Sciences Center to be faculty with the Department of Pediatrics. We had to figure out how to onboard new employees to cover some of the work that we're doing on the pediatric floor. And then COVID happened. We shut down. We had to figure out, okay, we were intending to do teletherapy services, and now we're going to be doing teletherapy services. So as many people experienced, that was a pretty quick overnight transition, and that we made happen and prepared our students the best we could so that we we could provide the essential services that we had started, providing in the first place. We have some coursework that's specifically designed to help trainees. And ultimately, having a half-time research assistant on the floor to provide direct patient care was a big step forward for us. And then later on, having an assistant clinic director to help with our medical-based clinic that you'll hear more about was a big step forward, and then grant funding pursuits to be able to address the needs in terms of sustainability. So here's our beautiful space that we opened in 2019, Children's Behavioral Health Clinic. It's co-located, it's directly at the end of the medical complex at the hospital. So we have our physical academic campus on the TTU side, and the hospital is on the Health Sciences Center side. And like I said, we have teletherapy being provided and a couple of grants that have helped us to support the operations that are both state level funding that has made it possible to continue what we're doing and expand. This little slide is really to highlight, this is our original presentation in the early stages of what we hoped that when we were on the unit that we would connect with families that were at risk, provide psychoeducation, assessment where needed, referral for ongoing services. And because we're in a pretty rural area, we have families that come into our hospital partly because we are a level 1 trauma hospital. We are a level 2 pediatric trauma hospital. So we are the medical hub for many of the families in the more rural areas. And I'm going to turn it over to Monica now to talk a little bit about our program model and who our integrated behavioral team consists of.
Yeah, so we take a very collaborative approach here. And so as a research assistant, I kind of moved from Texas Tech's system to working in the hospital at UMC. And so I'm part of the daily huddle where I meet with the social workers, child life specialists, nurses, and then medical resident, just to staff patients on the pediatric floor as well as the pediatric ICU. And so a part of that was just kind of gaining access to their EMR system, learning their system, and kind of meeting all those faces in the beginning of my role. And then also we have staff that are attending weekly staffing with our neonatal ICU unit, as well as the Pediatric Cancer Center. And then there in the Cancer Center, we do a lot of warm handoffs with the medical providers and the rest of the team. And so we take a preventative health approach and really strive to administer assessments, provide psychoeducation to the patients and families, as well as brief intervention. And so we developed some resources for the families just to provide some quick resources in all of those different settings. And then also within our integrated behavioral health team, we will kind of go over any severe medical trauma cases, just kind of reviewing the ones that are chronic or also have terminal illnesses. And then we've been really working hard with our program development as of late to just really kind of communicate better with the UMC staff and just the medical team. And so we recently kind of were working on some information and training for the medical providers on the pediatric floors and in the cancer center, just to kind of promote that communication and just let them know what we do. And so the next slide, yeah, that just kind of showcases our team. And so within the integrated behavioral health team, I function as a medical family therapist along as the research assistant. And so we're working with social work there, as well as child life specialists. And then to the left, you can see they have a medical facility dog. And so that is just kind of another component of our team. Just helping with children coping in the hospital has been so key, as well as Texas Tech sends over some psychology fellows as well. And so they kind of help with some of the assessments and mental health screenings. So in the next slide, this is just a pathway that we developed to just kind of highlight each of the roles. So we have social work, who's really working on providing resources to families in the community upon discharge. And then child life, like I said, is really helping with children coping in the hospital. And so we kind of found a gap where parents needed support too. And so that's us as medical family therapists came in over the last couple years and have really been able to help with that parent coping, mainly like around like anxiety with their child's illness or any severe medical trauma too, has been where we are able to provide support, as well as the psychology fellows, as I mentioned, kind of help with that mental health screening as well as the referral process. And then, yeah, we're also kind of continuing to build relationships with psychiatry as well. So,
Thank you, Monica. So the initial initiative was really to help provide information referral and brief intervention for hospital admissions on the pediatric units that were traumatic in nature, with the goal of reducing the likelihood of PTSD symptomology developing. And then around this time last year, we began having some discussions about additional needs specific to the Pediatric Oncology Clinic. And those are high utilizer patient families. And in those discussions, were able to establish a contract where my time at the university was actually split out so that I could be on site on a regular daily basis, providing services and facilitating the doctoral trainee and the service delivery for integrated behavioral health. So this is just really a slide that demonstrates the initial proposed plan. So we had some early onboarding last fall, doing some needs assessment, building the relationships, getting oriented to the system, the providers. And then in the spring semester, we spent much of our time around really moving forward to advancing the education of the, for the providers to understand how to access us, when to call upon us, who do they call upon, under which circumstances, and begin developing our research initiatives so that we can collect data to support the work that we're doing for the long term. And as we are closing down year one, we have a sense of what we've achieved so far and some of the things that we need to attend to, moving forward into the contract renewal. So let's think in terms of what are the needs, which is important to not assume what they are. Certainly our administration has communicated what the providers have conveyed to them is important, but we felt it was important to give them an opportunity to also highlight their requests, their needs. But the overall kind of research framework that we're using as we build this relationship, get feedback, use that feedback to continue to make improvements is a CBPR model. And so this model really operates out of patient-centered, community, focused approach, so that we're inviting the voices of everyone at all levels of the system to be able to speak to their experience and the needs so that we can develop the program that supports those needs best. So when we did the needs assessment, we were really thoughtful of, these are very busy providers. So we developed just a 10-question survey that could be distributed and completed, pretty easily. And I wasn't completely surprised, but the majority of respondents were identified as nurses. And so ultimately they have thoughts and they're on the front lines and they're in situations oftentimes when families are extremely stressed. And so two of the key questions that we asked them, one, what were the greatest needs or demands on their time from a behavioral health perspective? And then how are we doing in addressing or meeting those behavioral needs? And what they focused on in terms of the time demands piece was new diagnosis or relaying a diagnosis. Certainly when there's disease progression or recurrence or even a terminal status disclosure, those are the more difficult conversations and the more time consuming ones. And then in terms of how well we're doing, they gave us a 7, and I thought, okay, that's fair. We're fairly new to the system. Some of them don't even know we exist. Others do and call on us regularly. But ultimately, hopefully this feedback and the development of the program and the research that we'll be doing will help us get to a higher rating, where everyone feels like the behavioral health support is what it needs to be. And ultimately, anxiety and depression were really the greatest need that was shared by those that completed this needs assessment, and particularly around parent caregiver anxiety. Some of the gaps that were addressed in the open-ended questions in the survey were about how to find us, how to access us, getting support to the parents and the patients in distress at a timely fashion, and then what options are available for outpatient services upon discharge. Many of them were interested in us advancing our assessment process for the behavioral health needs of patients, attending and participating in team meetings, as well as providing some brief intervention in-house. So we're going to talk a little bit next. Monica's going to introduce how we have been addressing the information and referral process in a more formal way.
Yeah, so we developed these resource cards just for various units within the hospital. So within our pediatric ICU, we saw many medical trauma cases. And so, yeah, to the left here is just like that PTSD prevention, kind of just letting them know, like what to look for, like what are these signs, and then, providing some, quick coping skills that they can just scan with their phone. And so that was just to kind of support these patients during their critical care journey. And then in the middle here, we have our Pediatric Cancer Center resource card. And so this just provides information with just how to connect with the rest of our team for outpatient family therapy or individual therapy with all of our doctoral trainees and kind of getting matched to a specific therapist. And then we've been working on trying to provide some more support to parents and caregivers in the neonatal intensive care unit. And so we kind of were developing some support groups, and then also just letting them know like how to reach us as well, just to provide extra support. And then in the next slide, yeah, we've been kind of trying to get some research projects off the ground. And so, yeah, recently we submitted to IRB and are able to collect data for a MedFT trainee focus group. And so just to kind of get that feedback from, everyone who's been training within this new pediatric cancer center, just kind of getting just a better understanding of like what those experiences have been like, as well as we're in the process of hearing from the medical oncology providers about just this integrated behavioral health collaboration, as well as opening this up to a national survey and just hearing from other pediatric specialty care providers as well. We hope to collect data on that. And then also to hear from our patients and families and their perspectives as well. And so working on those IRB processes. Yeah. And then in terms of the clinical training and development, yeah, for me, I've been a research assistant here, working in the hospital as a medical family therapist, but then I've also been a doctoral trainee through Texas Tech University. And so we've all kind of had to fumble our way through the onboarding process, kind of like learning the Texas Tech side as well as the hospital side. And so that was kind of a process that we all worked together through. But then within our clinical practicum, we focused a lot more on just like learning about cancer and how to interact with these patients and families in this integrated setting. So we were able to have some lectures in our practicum about single session, brief therapy, and then just kind of identifying which interventions would maybe match within a stage of treatment for a patient and the family as well. And then we've had some complementary coursework as well as a medical family therapy course, a grief and loss with families course that is ongoing right now during the summer. And then, yeah, we as we got integrated into the cancer center, we have been working with Dr. Pyland, co-visiting with all of the patients and trying to build these relationships with the oncology providers and then also the patients and families. And many have been very receptive to our services in doing some outpatient therapy work with us as we've been integrating in this setting.
Thanks, Monica, for speaking to the training piece. I'm going to stop share, and we have a video clip from one of our trainees that Monica is going to share with you guys.
Yeah, so this is one of my colleagues named Kate, and she's just speaking to an experience with a patient who has a treatable tumor, but also experienced some medical trauma. And so she's been doing a lot of work with this patient and their family. And then also she'll just kind of provide a little bit of advice to any behavioral health specialist who's working in this pediatric cancer setting, just some advice to them as well. So.
Hi, my name is Kate Wagner. I'm a first-year doctoral student in the Texas Tech Couple Marriage and Family Therapy program. One family that really sticks out to me is one of the patients in the cancer center, a very close nuclear family. I've been able to sit bedside with patient and their family members and provide really great support for them. I have been able to not only attend their pediatric oncology appointments at the Pediatric Cancer Center, but I've also built enough rapport with the family to be able to follow them to places like their appointments at other parts of the hospital, like their surgery appointments. I've been able to witness their port insertion to start chemotherapy treatments, and I have been able to navigate some of the biopsychosocial issues that have come up both inside and what has preceded treatment, and also been able to help with coping skills whenever they are in the hospital at our facility. Because of past experiences of that medical trauma, it's really created a complicated environment for them to be receiving treatment here. I know that the patient's mother had even stated how meaningful it was to have people who can really go into their faith and provide them with faith-based components and grounding exercises through their treatment, going through this hard experience in their life that they never even imagined going through. But I also think that it provides a sense of comfort that there's someone in the room that's never poking them, never taking blood, never creating that trauma. That way, whenever, these scary situations do happen in the course of treatment, they feel a little bit more at ease. I think that integrated behavioral health in specialty settings, for the clinician, it can be absolutely rewarding. I think that it is some of the most rewarding work that we can do in our field. We're entering and joining in the family system. And so I would definitely recommend any integrated behavioral specialist to really be attuned to their self, to be seeking out self-care or their own professionals in therapy to be able to process these experiences. But you don't have to, maybe in a more of a traditional training setting, you're responsible for second order change. You're responsible for really healing these families from any presenting problem that they might come into an outpatient clinic. But in an integrated behavioral health specialty, that pressure for second order change sometimes can be taken off, and more of a focus is on the alliance that you're building, the rapport that you're building, not only with the patient and their families, but the providers as well.
All right, thank you, Monica. Anything more you want to add before I transition and screen share again? Okay, perfect. All right, Monica, take it away.
Yeah, so in terms of just kind of some feedback that we got from the oncology providers, they were kind of wanted to just know about some of the interventions that we were doing and with the patients and families. And so throughout our practicum, we decided to develop a curriculum that we can maybe use for future practicums. And so we found some interventions and just kind of all work together to pair different interventions to different stages of treatment. So like at the beginning of diagnosis, or, when can we administer assessments, or when do we want to assess the family system, to being able to provide interventions with that coping throughout their treatment, or as soon as once they get to maintenance phase, like what additional support can we provide them? And so in the next slide, we just have an example of one of the students developed like this sheet to hand out to families and in maintenance phase. And so some of the common things that we kind of wanted to address were, how do kids manage, body image issues or low self-esteem, anxiety. Some of the patients, experience hair loss, so how to kind of go back into school settings when they've been maybe homeschooled throughout some of their treatment. And I'm working with a patient right now as she's preparing for her senior year of high school and just had to take all this time away from school. And so it's like, helping her to, feel confident in entering back into the school setting. So this is just one example of kind of some of the interventions we've been doing with that.
Yes, thank you, Monica. So our hope is over the long term is that we develop a full curriculum. We actually test that curriculum with patient families in the oncology clinic and get their feedback about what's useful, what's not, and continue to refine the process of the ways in which we can best support them. So as Monica had touched on, we're also formalizing our assessment process, both with the pediatric ICU patient families and doing some pre-screening, but also having a plan for assessing all newly diagnosed patient families coming into the oncology clinic. And so I'm just going to move through these slides pretty quickly, but they really highlight what's available on public domain, or many of them are public domain. Some of them do have cost available. We are making a decision to secure an agreement using the pediatric assessment tool that is specifically designed for pediatric oncology populations. And then another option that might be available if you're not necessarily in an oncology setting, but you are in a pediatric specialty setting, is the CANS. As you see there, though, there are some annual trainings and some fees attached, but both measures are very comprehensive and looking at strengths within family systems as well as potential behavioral health needs. And so I hope this is a useful reference for you if you're in this process of determining which assessments might be a good fit for your setting. We also want to reassess families after discharge to establish, levels of stress, how they're managing, and we want to make sure that, they are not at heightened risk potentially for developing PTSD. So these are a couple measures that we're looking at for that purpose. And the second one does allow for both parent and child screening. If there is concern that trauma or other mood symptomology might be elevated, or there might be some indicators, there are a couple of options here. And should someone, reach above, the norm level for any of these anxiety, depression, ADHD, then the next slide kind of highlights that we can do advanced screening that's specific to that particular disorder, whether it's anxiety, depression, or ADHD. So of course, as behavioral health providers, we are interested in how are these family systems coping and particularly managing or regulating their emotions. So there are some options for doing that are pretty brief measures that are user-friendly and easy to administer within these types of settings. And as systems trained clinicians, we particularly want to maybe take a deeper dive in looking at what are some of their illness beliefs and how are they managing their routines and functioning as a family? How are they communicating? Because then that's going to help inform which interventions might be most beneficial when we're working with them, either in clinic or on an outpatient basis if they end up at the Children's Behavioral Health Clinic where we provide ongoing support. And coming back to that BPSS model, spirituality seems to be a common theme that families will reference as a part of their coping when we're engaging with them in the hospital setting. And there are a variety of options available. These are just a few that we would encourage you to consider that are brief enough, they're public domain, and help to understand what are maybe the beliefs or values that are driving the way that they're coping through this experience. What struggles might they be having? And again, it helps build a bigger picture of what it is that they need as we support them through this journey. So as we move into the last segment, I think we're doing fairly well on time, is we wanted to be able to capture some of the perspectives that the families could offer and helping us inform kind of next steps in our program development. And so we have invited a family to speak about the encounters that they've had with us. And the questions that are here on the screen are some of the questions that we've pulled from our interview guide that we will be using in the data collection for both the provider interview focus group study, as well as the family focus group study. So we'll have a couple of clips, and I'll screen share with Monica here in a second. One clip is from a set of parents that have been in treatment for some time and have encountered us in clinic on the hospital floor, as well as has pursued services on an outpatient basis. And then we will also hear from our chief pediatric oncologist about some of the co-visit experiences and the collaboration that we've had in clinic. So I'm going to stop share, Monica, and you can take it forward.
Since he was diagnosed with leukemia and it's a 2.5 year just about treatment cycle, your shifts and your needs of not just your child going through cancer, but we have another side, the sibling dynamic as well. We knew, gosh, like in February or March, like we needed extra support. I think that the mental health and getting support beyond just, Child Life does a great job when you're in the hospital, but you have to do the work outside of those days as well to make sure that everybody is good and solid, because we're the foundation for Cooper, for our son who has cancer. And so we've got to be solid for him to feel supported around the clock.
So it started, way back in diagnosis with Child Life. And then, kind of as we went through, as you get out and you're navigating everything, like I said, you kind of, you see the other things that need attention. You can see what's happening. It's very hard on everyone. And so, us being able to, to get with someone and talk about things. And it's been really good for us, I think, as a family, because, it forces us together and to talk and for feelings to come out. And it's kind of like you don't want to have those conversations and talk about those feelings. But once you start doing it, everyone's kind of like, I have those feelings as well, and it kind of brings everyone to go like we're all feeling this way, and then also you hear stuff that you had no idea that someone was feeling that way. And then it brings, and then you're like, geez, I totally missed that. I didn't know that. And so you can, react to that, and you can, change that. So, and none of that would have happened had we not, been able to speak with someone and talk with someone.
So it's good to have a trained professional who's there and can ask those hard questions. I see tremendous improvement in our communication skills with one another, but even with other people, like we advocate a little bit harder, but in a more effective manner than we did at the beginning. from last year at this time to this year, like pre-therapy, but still doing chemo and all the cancer things, to this summer, how much more at peace even our house is, like, because you walk around on eggshells, because at any minute, when you have somebody in your family who has cancer, especially a child, numbers can drop and you have to have contingency plans, and you're so focused on that child, you don't think about the sibling and what's going to happen with them, and does a parent stay, all these questions. And I feel like now we're just kind of like at peace, where we know that we can communicate through it, and we know how to better effectively communicate with, both kids.
Yeah, so that helps kind of give you a sense of their experience of getting services outside of the clinic, and speaking to the gains that they've achieved as a result of getting family therapy in addition to what they're getting in clinic. And so now Monica's going to pull up a clip with Dr. Al-Rahawan, who is going to share a little bit about his experience and the ways in which we have supported families, particularly around the more difficult end-of-life issues.
No, I can't think of a more challenging situation than having to deal with cancer as a child. That by itself presents so many facets to the emotional aspect of this. The first one that comes to mind is in a teenager, as they're trying to assert their personality and self, be more independent, less reliant on family, and defiant of the parents' opinions. Suddenly they're struck with a thing that paralyzes all their aspirations of independence and strength and shining and having a social circle and having a popularity in their social circle. All that is struck by their diagnosis, by their life on the line, by the sometimes not disfiguring, just hair loss, and sometimes disfiguring situation. I believe that every child who's diagnosed with a cancer, be it great prognosis or poor prognosis, when it comes to cancer, they should meet with the child and marriage and family therapist early on to get to know them, because you even through the good times they need help how to deal with this situation. It's always good to introduce it early, but some families need it more because things don't go as planned. I've had a patient whose life was on the line. She knew that she will likely die of the cancer unless she gets IV chemotherapy, and she said, well, my hair is more important. Unless you convince me otherwise, I'm not going to proceed with IV chemotherapy. And even though the family was reluctant to allow her to make that decision, they realized that it was clear in her mind her priorities, and she went along with them for a while, but then she brought them back to come along with her for the next while. And during that time, your role as a team has been tremendous. We had good one-on-one conversations, team conversations inside the hospital, outside the hospital, in the clinic, that helped us all keep moving in a direction that is centered around the patient herself, not around what I think is appropriate or what someone else's thinks is appropriate.
Yeah, I think that's a great example of family-centered care that, we strive as medical family therapists to offer to patient families that are being treated in the clinic. Yeah, so thank you, Monica. So as you heard, there are emotional needs. Sometimes they're not as heavy as end-of-life care, but ultimately there seems to be an appreciation from the providers that we can be in the presence of those conversations. And I use the word kind of catch the grief ball, if you will, and supporting the families during those more challenging times. So So let's talk a little bit about what have we learned over the past year with this expansion, and I'm turning it over to Monica for that.
Yeah, so we would definitely not be where we are today without our CMO, Dr. Payne. He has been our greatest champion, just with coordinating with the medical providers, the board members at the hospital, as well as our Texas Tech College administration. Additional champions are faculty, Dr. Paland, yourself, and also our doctoral trainees. We kind of have been termed as like the guinea pigs, kind of just we're all working together to kind of figure out how we can better support these patients and families. And so that's looked a lot like just kind of fumbling our way through access to different systems and trying to work our way around maybe some space limitations as we kind of try to integrate into the setting. So it's really been helpful just to be open to all the different perspectives. We all really just want the best for our patients and families. So working together and kind of covering each other if there's a medical crisis or, catching the grief ball, we've had to just kind of provide that coverage, or maybe kind of drop everything sometimes within our schedules just to support these in the moment crises. And it's been a process over these 9 months. I think we've seen a lot of feedback within May and June of this year. But we started this way back last year at the end of 2023. And so just seeing how it's been a process along the way. And it's just important with those collaborative relationships, that change is hard with the system that we entered into, and we have our own system. And so just kind of trying to bring that all together has been a process, but we've just learned that collaboration is so important and just communicating and kind of just like those simple things that, sometimes we forget while we're trying to get things done. And yeah.
Thank you, Monica. Yeah, so I tried to think back about, okay, what would I offer to someone that, maybe is stepping into a similar situation as I did about a year ago. And one of the things was just to utilize your implementation plan, refer back to it. It's a good way to kind of have a checks and balances of, okay, what did you say you were going to do and what have you accomplished? What do you still need to address or focus on next? I do think too in the beginning, because there are so many providers, there's many levels, operational, financial, unit leaders, and different personnel. Having a master contact list, although this sounds kind of simple, but it's very quickly it grows and you're backtracking through emails and you're trying to find names and numbers that have been shared with you. So developing it as you go and keep building it so that when you need to reach out specifically to someone related to a need that you have, that you've got that available. And of course, tracking everything you do. I mean, we have been fortunate to be supported by the hospital, the foundation, in terms of my time and Monica's time, as well as the space that we use for the CBHC. And we need to be able to establish what we're doing, how many people are we impacting, how are we making a difference, which is also why we have the research projects and development so that we can fully capture the experiences and the narratives of everyone attached to this initiative. People are busy. It's important to respect other people's agendas when you're asking for a meeting, that you're prepared. You have, kind of a list of questions that you want to address, providing any information that they may need from you. And to know that you're just one aspect of a much larger system as a behavioral health provider, particularly. And when you do have requests come your direction, to try to respond in a timely manner. That may be specific to a crisis consult. It may be just to brainstorm for, what are some expansion moves that people are interested in taking so that you can continue moving everything forward. And, you know, it wouldn't be right not to speak to some of the potential barriers, right? These program expansions can be clunky at times. I think one of the things as a clinical supervisor and co-visiting with the doctoral trainees that I came to realize is that one size does not fit all. Not everybody wants to work in a medical setting. And so when Monica spoke to kind of the guinea pig factor of our doctoral trainees, I mean, they basically were told, you're going to be doing some clinic-based work. And, you know, there's people that have, you know, blood aversions and, you know, needle aversions, and all of those things are happening in a clinic setting. So it's important to recognize that you may need to screen your students to be aware up front of who might feel a little queasy about, you know, entering a medical setting, or who might have a medical trauma of their own as they are, you know, being put into this setting. Technology, you know, our networks don't get along. So I think I spoke earlier of, you know, we have the campus side, the academic side, and then we have the medical center side, and they're completely different networks. And so it is blocked by a firewall to be able to access each of the systems across campus. The other piece, because we are in West Texas, we actually have a fair number of Spanish-speaking patients that are not bilingual. And although we have translation services, which is essential, it does increase your time demand. And so you have to consider that, you know, going in for a visit that might just be 10 or 15 minutes could be double that, just because you've got the translation component at play. And then last, I'll just say schedule constraints. You know, Monica is half-time. I'm essentially half-time between campus and over at the medical center. And when crisis happens, they're not on a schedule. And so it can be difficult to transition between each site. I mean, even right before this presentation, I was with a young adult patient, you know, who's facing into life and is about to go home to finish out his final days, and then coming back over here and switching gears. So sometimes we're faced with really difficult emotion laden encounters, and then, you know, we're on to the next task. So here are just a couple of things in terms of where we would like to focus moving forward in terms of a 3-year plan. And I'm not going to spend a lot of time here. Y'all can read the slide because I want to be able to leave a little bit of time for Q&A. But ultimately, further integration, additional funding for sustainability, and developing some annual events for the families that, as behavioral providers, we feel could be really meaningful in their process. Long term, we would love to have greater integration. We have a pediatric orthopedic surgery clinic who has reached out to us. They discovered that we provide services and would love for us to be in clinic at least on an, you know, occasional basis, because they are dealing with definitely life-changing, you know, limb amputation adjustment for the patients that are seen there. We also have patients that when they've had major surgeries, that they end up being transferred from the hospital for rehab. And then obviously with a terminal diagnosis, our patients are transitioning to hospice care. When I began this journey, one of the other pieces that I was feeling like was maybe needing attention is that I benefited greatly from the pediatric and integrated primary care guidelines, because I felt like I needed something stepping into a specialty care setting, which I had never worked in, and being able to have some guidelines to help inform the development we were working towards. And so that is my hope long term, that we can somehow contribute to that from our experience. And then we've spoken about the intervention curriculum for the oncology clinic, and then expanding and having additional funding where we can have a postdoc fellowship for folks that want to come and particularly have a specialty care training experience and considering this as a career path for themselves. And we have so many people to acknowledge. I thought about creating a slide of putting all the faces of everyone that's been involved, because we wouldn't be here today without so many people that have committed to this cause. And so we have deep appreciation for the privilege that we hold to be able to do this work. Okay. I think that's it. We did pretty well, Monica. We managed our time, and we still have a few minutes that we can open up for questions.
Looks like we have one in the chat.
Okay, let's see here. All right. Oh, like to hear about our contract renewal. Who are the parties to the contract, and what role do your outcome data play in this process? Yes, thank you, Mr. Haddock. So we will submit a similar initial contract that we used last year. We'll probably revise and update that after we meet with our administrators to get feedback from them and make any relevant revisions. So it has to run through both the University Medical Center legal, the Health Sciences Center legal, and the TTU main campus legal in order for us to process those. And it was incredible last year. They were so responsive and made it happen with a really pretty quick turnaround. This year, hopefully it won't be as under the gun as it was last year, since we have something to work with. In terms of our outcome data, we pulled our encounter numbers from our EMR and produced that to our administrators to present to the foundation in their decision making to continue to support our project. We also have our clinical trainees record all of their time within the Children's Behavioral Health Clinic, and we produce monthly data on the encounters and the service hours and the numbers of families and children that are benefiting from all of the service delivery that we offer. Okay, so great question, Angela. In terms of sustainability, at this time, we are not processing insurance. And part of that has to do is that our doctoral trainees are pre-licensed, or at least associate level licensed. So many of the third-party insurer payers do not allow for billable time for a pre-licensed clinician. However, some of the discussions that we have had have been figuring out whether or not some of my direct time could be billable. And that is one of the things that we're looking at as we're going into year 2, so that there can be some income that's coming in to offset certainly some of the costs that go with my time. So great questions. Mainly what we've done in terms of funding is found grants, and the HOPES grant and the TCHAT grant through our state has allowed us to pay our staff and our clinical providers to provide services to the families for free, so that we can operate and yet the families can get what they need without a charge. And then for the rest of those that don't qualify under our current grants, we do offer a fairly reasonable sliding fee that most of our families can afford. Any other questions? Okay. Well, our emails are in the chat. If you have any follow-up questions, both anyone that might be a trainee out there and wants to hear more from Monica, or the folks that are a part of her cohort, or directly from me, I'm happy to also share my wisdom. I benefited from all the people that came before me and the resources that I was able to get my hands on, and I couldn't have done it without many of the warriors that have done this work for many years.
Thank you guys so much. This is just really cool work that you're doing. So I'm glad we got to spend some time hearing about it. I don't see your email, so I may have joined after you shared that. If you want to share it again
problem,
for
yeah.
everyone to have access to.
There's mine, and then Monica, you can just add yours.
All right. Thanks, guys. This was great.
Thank you. I appreciate it. All right. Any last call for questions? It is 11:56. All right. So Angela, will you be securing the recording, or Brittany is doing that? Okay. Because I know
Yes,
Yeah.
make sure.
some
We'll
of
make sure.
our administrative team may be interested in having access to it, if that's an option for us.
Yes, it should. I think it usually takes about a month, but then it'll get posted and it'll be available.
Okay, great. And if you guys have any feedback for us, this is really kind of a dry run in terms of the presentation we plan to do at the conference. And so any feedback that you can offer to us in making modifications, we would love to hear.
I thought it was so great. I really especially love the video clips. It adds a lot of depth to what you guys are talking about, and just really how you broke it all down in the different steps that you took. Great graphics that help break it out. I honestly don't think there was anything I would change about it.
Oh, you're so kind. Well, thank you. But yes, I'm always a big fan of hearing the lived experiences, and those are always some of the favorite presentations that I've attended, over my career. So we may have additional clips and may have to decide what we cut if we want to be able to, have more expanded clips or representation of different unique needs. So we'll see what data we have between now and then. But thank you for your feedback.
Yeah.
Okay.
All right. Well, thanks, guys. It's great to see you.
Log out. Okay.
Thank you
Y'all
so
have a
much.
great day.